afternoon, everybody. I was trying to show off, and whenever you try to show off, it always comes back to bite you. I am getting older and not quite as nimble as I used to be. But anyway, I am Tim Zemer. I am privileged to be the coordinator for the President's Malaria Initiative. I think most of you in this room are either partners, supporters, or colleagues, and it's good to see so many familiar faces. I feel fortunate to have been invited to say a few words to you and to this workshop as we acknowledge some of our key partners and then share information, lessons learned, best practices, and what didn't fall into the best practice area that we can put on the table and consider so that our output and our impact on behalf of the country and the constituents that we serve will be improved. I had some prepared remarks, and when I walked in here and looked at the audience, I decided to keep my prepared remarks in my pocket, and if you'll allow me to just make a few personal comments, I'd appreciate it. And then, regretfully, I have to leave. I have an out-of-town guest that's here, and I have to go over and kick off another meeting. First of all, as I look over this room, I want to express my personal thanks to each of you. Even though I don't know you, I know that you're here because you're committed to an organization, a country, and a cause. Public health, probably malaria, or an organization or a mechanism that supports malaria and health in a specific place or country or region. I didn't begin my life as a public health specialist. After I finished university, I started my career flying airplanes for the United States Navy. That was pretty exciting. I learned as a pilot, it was my job to look for hostile airborne targets as well as hostile targets on the ground. I find a lot of comfort in my job today because one of our targets is a very hostile airborne target. It's called a mosquito. And I tell many of my audience friends here in the United States that my job is to take on one of the most dangerous animals in the world. And everybody holds their breath, and I say it's the mosquito. And all of you in this room understand the adverse impact of that insect and the carnage that it carries to our communities, our villages, and our families, and those that we love so much. And so as we spend time together today to look at programmatic work, the past, what we're doing together as partners, and positioning ourselves for the future, there isn't anything more important than we can do. Let me put my program hat on for just a minute. Over the last 5 years, the United States government, through the President's Malaria Program, has been fortunate to see and participate in the very encouraging trends that we see reported by WHO, specifically with the countries in sub-Saharan Africa. When you look at the reductions in the morbidity and the mortality rates, when you look at the reductions in parasitemia in some of the districts and provinces, when you look at the rates of improvement of positive diagnosis that's happening from 5% in 2000 to as high as 45% in 2010, diagnosing people with fevers so that we can get them treated with effective ACTs, that's encouraging. We're all optimistic about those trends, but all of us are holding our breath about the future. I spend most of my time today talking about the successes that you produce as partners with the U.S. government in the field to my colleagues up on Capitol Hill. Our Congress knows the President's Malaria Initiative program very well. They consider it one of the most effective U.S. government foreign assistance programs. The last time I went up to a hearing as part of a public health meeting, they ran out of time. And so I didn't get a chance to make my comments. And as I got ready to go, I asked if they wanted me to come back. And one of the staffers said, "No, we know the malaria program. You're doing okay. We won't need you to come back." Now, that's a nice compliment, but I would like to reverse that and turn that around to you, supporting partners here in D.C., our staff at USAID, CDC, and in the country, but more importantly, to the front two rows over here to my left, the partners in the field that have come to represent the significant impact that our NGO partners are having on behalf of the country programs. If you look in our annual report, you'll notice statistic that the PMI program has over 220 NGO partners, of which about a third of those are faith-based partners. After I left the Navy, I was privileged to run World Relief, which was a faith-based NGO out of Baltimore. We were in 26 countries. And that's when I got my training wheels on the significance of NGOs and the faith-based organizations in terms of their impact as partners, assisting countries and communities in their fight against different causes. There's no doubt in my mind that without a strong commitment to the private partners, NGOs, the U.S. government programs would not be as strong as they are today. And so I just want to communicate that this administration, our President Obama, Secretary of State Clinton, Dr. Raj Shah, the Director of Foreign Assistance, all acknowledge and embrace the role of the private sector as well as the private partners, NGOs in the field, in order to have high impact and make our dollars go further and to be more successful in achieving country goals. So as you go through your discussion in this workshop and communicate lessons learned, best practices, some of the practices that were not so good, I want you to be very honest so that as we have an opportunity to share, we can look at building better programs in the future. And the U.S. government, USAID, and the President's Malaria Initiative is committed to continue to develop business plans through our USAID missions to support country plans and leverage other donors' contributions so that we all come together with a single plan, chasing and moving out towards common goals on behalf of the beneficiaries and the people in the communities. That is not just rhetoric, it's a goal and a commitment that is shared above me, and I'm really pleased to be able to communicate that on behalf of our national leadership. One other thing, I do want to plug our U.S. Congress. Right now, they do not enjoy a very high rating in terms of reputation and success. But our Congress is strongly behind global health and have been significant supporters of the President's Malaria Initiative. And every chance I get, I do acknowledge the bipartisan support and the appropriations and the dollars that they send our way to support our commitment to fighting malaria around the world, specifically in sub-Saharan Africa. So, those are my personal remarks. Again, I want to thank our partners, primarily those in the front two rows. Thank you for your work, the efforts, and the impact that you're having. And for those of us in the rest of the room, I look forward to continuing to work with you as partners, as suppliers, so that as we continue to work towards our targets and goals, that we will continue to show measurable impact in all that we do. So, thanks for allowing me a few minutes to share a few personal thoughts. Have a good rest of the panel, and I look forward to hearing from my team on what you all discussed. And I promise to follow through on any action that you pass along. Okay, have a good afternoon. Thanks.
Thanks to Admiral Zimmer for that great introduction, and thanks to all of you for joining this afternoon. I'm Deborah Prasnitz from MCHIP, one of the technical advisors to the Malaria Communities Program, along with Alona, who's here in the front row. And today we have 7 representatives of grantees of PMI's Malaria Communities Program, as well as some PMI staff, and I'm going to let everybody go ahead and introduce themselves.
My name is Evaristo Waya, and I am the programming officer for ADPP Angola.
I am Macpherson Kapalamula, the project director for Malaria Communities Project concerning Veso, Malawi.
My name is Roland Swami. I'm the program director for Equip Liberia.
I'm Dr. Patrick Hukelo, the program manager for Malaria Communities Project, Medical Teams International, Uganda.
Good afternoon. My name is Charles Zangira. I'm the project director, Health Right International, Kenya.
Good afternoon. My name is Deusdedit Mjungu. I am the project director for Malaria Communities Program, which is implemented by Christian Social Services Commission from Tanzania.
Good afternoon. My name is Ambesutola Feisa from Ethiopia, FAIA Integrated Development Organization, Director of the organization. Thank you.
Hello, my name is Megan Fotheringham, and I am on the MCP management team for USAID PMI.
Hi, I'm Susan Newell. I'm also with the Malaria Communities Program management team at USAID Washington and the President's Malaria Initiative.
Okay, well, thanks everyone. And as Admiral Zimmer alluded, we're actually here just to have a discussion. So we have a number of questions, and we'll just engage in a discussion amongst folks here. So I'm gonna start off with the first question, and just raise your hand, and we'll pass the mic to you, and you can respond, okay? Okay. ITN ownership has increased dramatically since the inception of PMI, but consistent and correct ITN use continues to be a challenge. How have your projects addressed this, and how have you fostered community ownership or responsibility around care and use of ITNs?
Thank you very much. I think it's really true that in terms of ITN promotion within the projects, the use and the consistent use, I think, has been a challenge. But as a project that's concerning Veso Malawi, we realize that before we do any promotion campaign, people have to be aware of the product, that's the net itself and how it's going to be used. So through mass awareness campaigns, which were coupled with theater for development dramas, but also actual net demonstration on how the households could use the nets, that strengthened the ability and also the capacity of the households to be able to use the nets. But also through the community structures which we have been trained on malaria promotion, the community structures or the community volunteers has been visiting the households just to ensure that they have properly hung the nets, but also they are using the nets as per advised. But also as a project, we have been doing the post-net distribution surveys, which we usually do every 6 months after distribution, but also 18 months after distribution. In terms of this post-net distribution survey, we are trying to make a follow-up to the households which have managed to receive the nets to see if the nets are available, in what condition are the nets, and also have a spot check on the net hanging, if the nets can be in the house but not being hung properly. So these are some of the initiatives we have been trying to promote within the committees so that they are able to follow up and able to document that the nets are being used properly, correctly, all day throughout the year. Thank you.
Okay, thank you. I would like to start saying that our MCP projects in Angola were implemented in the province where there were no mosquito nets. We have started our projects by doing baseline stats. That shows that it's not because people don't want to use mosquito net, but they were not available in the communities. So we are using the school base as a philosophy of the projects where we train teachers and the students in the schools. So during the period of the projects, also we had good cooperation with Mentor, who has distributed mosquito net in the communities. And then we had a project about behavior, communication for behavior change. So the students, they went to house to us to see how people they are using the mosquito nets, if they are using in the correct way. Because as they didn't use before, it was very necessary that to teach them to use correctly the mosquito nets. And then we have formed groups in the communities who can follow up on 2 weeks basis to check whether the families they are using the mosquito net.
Okay. In addition to partnerships with local district ministries of health and facilities, your projects have all developed strong partnerships with community structures and facilitated linkages between these community structures and the formal health sector. Can you discuss your partnerships with different community stakeholders and the effects that these have yielded on your projects?
Okay. This is a very interesting integration or linkage between the informal sector and the formal sector in managing health issues within our communities. In that, we are having change agents. These are community health workers, community health committees. We have the CBOs. We have community-based organizations that we work around together with. The main issue or the main strategy that is being used here is capacity building of the local structures. These are the agents, or this is the level that is bridging, because we are having the levels of health management that is running from level 2 to level 6. So you find that there is a gap to bridge the households and the formal levels, that is level 1, where we are having trained health workers. So you find that the CHW is collecting information that concerns to health issues. Then the information collected is being reported to the health facilities. Then the linkage continues up to the policy level, that is at the national level. Then you find the same is replicated, that should there be any policy that is supposed to reach the household, is also going through the same channel, where you find the link person between the CHW and the health sector is called community health extension worker, who supervises the CHWs and then feeds the formal health system. So this is how we work, and currently, as we are talking, we have even community based organizations that we've trained, and they are working hand in hand with the formal sector, that is ministries of health, Ministry of Health as per se, because we are now having Ministry of Public Health and Sanitation and Ministry of Medical Services. So this is how we work, and you find that the CBOs, the community-based organizations, we've trained them in various areas to the extent that now you find that they are running like we've sub-granted them in that we've given them a section of our objective, that is the objective 1 of our project, that is focusing onto the capacity building and running all reporting and doing monitoring of activities at the very local level, that is household and within the community level. So this is in a nutshell how we run that section. Thank you.
Thanks, Charles.
Thank you. In our case, having recognized the importance of community partners, right from the beginning of our project implementation, we identified the core groups of partners in the community whom we shall be working with. Now, these groups include the community village leaders. In our setup, we have the village leaders and ward leaders. And these are the lower level of the government administrative system. That when it comes down to the village, we have the village chairman and the village executive officer. These are the recognized leaders who are there to oversee all the project activities in the village, who are there to report to the higher levels, the district commissioner of whatever progress is going on in the village. So having known the importance of this type of community leaders, we engaged them. We gave them 2 days training so that they should know what the project is after, what are the objectives of the project, and also we tasked them to oversee the community health workers implementation activities.
Dr. Mujungu, in addition to the village leaders, did you also work with religious leaders? Can you talk about your engagement with the religious communities?
Yes. Yeah, in addition to the community leaders, we also engage the religious leaders. These are another key partner to work with. Religious leaders, they have people behind them, and they are very respected in the community. And therefore, we trained the religious leaders after we have developed the malaria ceremony guide training. We collaborated with the government to come up with the document, which will guide the religious leaders to sensitize their fellows on malaria issues. So we after we had the malaria ceremony guide, we trained the religious, that we gave them 1 week training so that they are aware of the various issues pertaining to malaria, various malaria prevention messages. And then they went on using this ceremony guide training, ceremony guides to train on sensitize their members in various religious congregations, maybe in Sunday schools or in wedding, in funerals. So through that way, religious leaders have been appreciating, and we saw things moving, because on average per month we had 100 religious congregations being done by religious leaders. So it's another key partner whom actually helped the project to move forward. We also made use of the community health workers. As I said before, these were the cornerstone of our project. We gave them training, and then we tasked them to go house to house to visitation to provide malaria prevention messages, but also to attend various community meetings which are conducted in the village. And in those meetings, they provided, they used to provide malaria prevention messages under the supervision of village leaders. So, and another strong stakeholder, community stakeholders, were the primary school health teachers, being recognizing the importance of primary school health teachers, that they are also respected in the village, that they are learned person who actually they are dependable on when it comes to issues of malaria and other scientific issues. So we trained them on malaria prevention issues, and in turn they trained the pupils, but also they went to train the village development committee members, because they are the members in the village development committee members. It is a committee of 25 people who oversees the village activities. So in that way, we found that we had a link between the community and the higher levels of health provision services. Thank you.
Great, thanks. So you mentioned kind of a new community partner that's now of greater interest, which is school teachers and school children. And I was hoping that Evaristo could talk a little bit about that, since that was really what ADPP Angola's project was kind of formed around.
Okay, ADPP Angola has a long-term agreement with the Ministry of Education to train teachers for rural areas. It's experience from 25 years. And also we have agreement with the Ministry of Health about the reinforcement of community health. Therefore, based on this agreement, we have made this agreement on the provincial level to make sure that the province, they can include malaria as an extra curriculum. And then we made the agreements on the municipal level with education and also with the health clinics. And then also we made agreement with the private sector, like oil company who provided the mosquito nets to the projects, and also PSCI. So in this structure, we have using the school, as I said, as a base. And as we have already this agreement with the Ministry of Education, it was easy for us to work in the schools, in the communities, because we have already teachers in the communities who, besides of being a teacher, as not a teacher, also they do community work. So we combine these two activities, and then they are respected in the communities. They have a connection with the local authority, with SOBAs, and also they are good connection with the health clinic. You can imagine that after all, one of the problems that we have in Angola is the lack of human resource with the capacities and also infrastructure. So to have this kind of teacher who can be a good teacher in the classroom and also can be a good community activist who can promote malaria awareness, it's very important for provinces like where we're working. Then we have, to secure the sustainability of the projects, we have trained the clubs for teachers, club for students, what we call patrols. So those clubs, they will continue to connect with the LC Center to continue with the campaigns. Just to give you one example, right now Angola has a commitment for universal coverage of mosquito nets. We are going to distribute about 10 million mosquito nets. It means 1 per 2 person. So in the province where we've been working, our patrols, our teachers, also they are part of the campaign to secure that people, they will get mosquito nets and also they will use them.
Thanks. So malaria in pregnancy remains a challenge, and most countries have not made significant progress in this area. How did your projects address malaria in pregnancy, and what best practices or lessons learned can you share with us?
Okay, thank you very much. Malaria in pregnancy remains a very big challenge, as you have said, because it tends to be more common, more severe, and more fatal. And in most cases, it's also challenging to treat for the physicians. So in our project, we had one of our key objectives to prevent malaria in pregnancy through increasing IPT2 uptake, especially IPT2. So what we did, in our country, we have the volunteer health workers that we call village health teams. These are community volunteers that are selected by the communities themselves and trained by either the Ministry of Health or an implementing partner who intends to use them. So for us, we pick the female VHS teams and train them. We train them on what is called goal-oriented antenatal care. Goal-oriented antenatal care is a new package of antenatal care which emphasizes that a pregnant mother should go for antenatal care at least 4 times. Through these visits, she would receive a package of health interventions, including IPT, TT immunization, identification of complications that might complicate her pregnancy, and also identification of existing infections like HIV and others. So since goal-oriented antenatal care had a component that our project wanted, that is IPT2 uptake, we trained these female VHTs in our catchment area and assigned them to help in antenatal care facilities. So what they would do is, in their respective villages, they would go and mobilize the pregnant mothers, the pregnant women, to go and attend antenatal care. This saw the antenatal attendance improved, and in addition, while in the antenatal care clinics, they would give health talks. When the pregnant women come, they would talk to them about malaria, how it presents, how to prevent it, what to do when it gets you, and even when it gets to a child, what you should do. So this also showed the level of knowledge that the mothers had to increase. And in addition, these female VHTs would ensure that these pregnant women who are eligible for FANSIDA would take it there and then as DOT. DOT is a strategy being used by the Ministry of Health in Uganda to ensure that these pregnant women take FANSIDA, that is SP, as directly observed treatment. So this intervention was an innovation for medical teams internationally in Uganda, and we have seen it work. It has seen our IPT tool, which is the indicator used in assessing IPT uptake, increased from 25% at baseline, that was in 2009, up to 80% this year when the project closed. So we are convinced that the female VHTs, when entrusted and trained, they are able to do better than the men. In our country, men are not always very much committed, but we have noted that females are always very committed because they are concerned about the health of their children, health of their fellow women, health of their families. And we think this is a strategy worth adopting. We have recommended this to the Ministry of Health Uganda and to the Malaria and Pregnancy Sector Working Group, Ministry of Health Uganda, and they think and they agree with us that it's a strategy which has really shown results. We have also noted that using these female VHTs gave these pregnant women confidence when they come to the health center, because they know when they come, there's a person who also came from their village and is working there. So when they come, they easily connect. Otherwise, others would get fear as I will go there, how will I know my direction and whatever. But this, we have seen it has improved. And it has not only helped in increasing the IPT2 uptake, it has also encouraged even the men to come. Because when these pregnant women come, the female VHTs teach them and tell them to come with their husbands or spouses. So these men, when they come, the female VHTs also engage them in health talks and make them participate in small skits. So the men also get to learn the importance of bringing their women for antenatal care. So this has also seen the attendance, the men accompanying their women for antenatal care also has improved, and we think this is a very good strategy. We have noted that this is a best practice, and we recommend it for further scaling up in our country and also in other countries which we could be having similar situations. Thank you.
Thanks, Patrick.
And I want to, in addition to that, in Liberia, what we have done also is distribution of RTN to pregnant women at the health facility, because we know that the mosquito net, once they are using it, help to prevent them from getting malaria. So the Ministry of Health, in collaboration with the partners, ensure that pregnant women that come to the clinic for ANC visit are targeted for net distribution.
Global recommendations and best practices, and consequently many national policies for malaria diagnosis and treatment, have evolved over the course of the Malaria Communities program. Diagnostic policy in particular has been an important change following WHO's policy moving away from presumptive treatment. How have your projects responded and contributed to these changes at both the community and the facility levels?
Okay, thank you. As concerns this, it falls within our objective 2, within our project. That is where we are working together with the health systems. That is where we are working together with the health management teams and health management boards of the health facilities. So you find that we are engaged in building the capacities of the health professionals that we work with, to the extent that up to now we've done the mentorships. This is a continuous process that we support, as we are normally supporting our supportive supervisions, that we move out together with the health management teams as they do supervision to other health facilities within the rural setups. Then you find that the new regimes, the new policies that are there, are being mentored onto the subsequent health professionals within this setup. And then the next thing that you find we've been also engaged within this setup is also the health information management systems. We are also helping in monitoring the drug or the ACT stockouts, and we help in reporting the same. Then you find that up to now we've done the RDT microscopy training that we've supported, working together with the Division of Malaria Control and other agencies that we work with in partnership. Then we also done the malaria case management training within the region where we work, and the staffs are already equipped with the knowledge and information that is necessary for effective management of malaria. To add on to that, we've done the RDT pilot survey, the study we've done, and the results are out that we are yet to share with everyone. But already within the system, we forwarded up to the Division of Malaria Control and even to the USAID offices. So this is how we worked up to this extent.
In Liberia, also, we noticed that we have been working in the community doing malaria control and prevention activities, but the epidemiology report continued to show increase in malaria cases, which means that people were just treating suspected cases of malaria without actually doing RDT or microscopy. The Family Health Division of Liberia have the MCR protocol where any child that comes to the clinic with fever, without doing any tests, you just go ahead and treat for malaria. So this was actually increasing the cases of malaria, which was not really true. So we met with the National Malaria Control Program and the Family Health Division to make sure that they can harmonize their policy. And now what has been done is that before you treat any child or any case of fever in Liberia, you have to either do RDT or microscopy. So people at the health facility are being trained, and it's a matter of policy in the country that before you treat, you must do confirmatory diagnosis, and this has actually helped to increase the competencies of our health workers, and also those at the community level before they can treat any case of malaria. Thank you.
Thank you very much. And in addition to that, in Malawi, the project was part of the technical team within the National Malaria Control Program. And during the implementation of the project, we noticed that there was some shift in the terms of the policy for malaria treatment, whereby we have been using SP, and the country changed the policy to use of LOA, as the first line drug. So the project made a crucial advocacy in terms of disseminating the change of that policy from using SP as a first line drug for malaria in Malawi to use of LOA as the first line drug. So the project made a very significant impact in that particular change of policy. But also, in addition to that, the project, through the Against Malaria Foundation, we managed to source some nets which we distributed freely. And that model was adopted by the Malawi government when they just did the universal free net distribution in Malawi, which happened this year. So the model which was followed in the country was copied or was modified from the model which we use in terms of the free net distribution in Malawi.
Okay. Supervision is increasingly recognized as one key component of a successful CHW program and one that's linked to staff motivation. What kind of supervision systems did your project implement, and what challenges and successes did you experience?
In Liberia, the Ministry of Health at first was against giving malaria ACT to community health workers to treat at the community level. So when we advocated that this was necessary, this was going to help to decrease the cases of malaria at the community level, we were given the opportunity to pilot the CCM project. And when the community health volunteers were selected and doing our training, we know that people were at different levels. There are illiterate people, semi-illiterate people. So during the training, we noticed that supervision was going to be one of the key if we have to succeed in our project. So what we did, we put a system in place, which we have our regional supervisor, which are RN, PA, or CN, to do the supervision of the community health volunteer on a monthly basis. Then we also have another level, which the assistant supervisors, then we have community health trainers, which are peer supervisors at that level. So on a monthly basis, they supervise the community health workers at the community level to do supported supervision, to collect data and analysis. Then we also have a M&E team that comprise of members of the National Malaria Control Program and also the Community Health Services Division and the program manager for EQUIP. So all of us do each and every month we also do a monitoring visit to visit each of the community and each of those GCSV to ensure efficiency, to ensure that they are providing the quality services that they're supposed to provide. Tools that are used during supervision, we have this checklist that people, that was developed. So as you go, each GCSV toolkits are looked at, their GCSV patient registrar are looked at. You interview the caregiver at the community level to ensure that they have been treated correctly and accurately, and all these things are documented. And also you have to look at the competency of the survey provider, which is a community health volunteer during your M&E visit. Of course, there were some challenges. Some of the challenges were bad road conditions in the interior, especially those communities that are far up to the border area. Then we also have challenges that there's no cell phone coverage in most of those communities, so that you will get there and the community health worker you're supposed to supervise is not available, so you have to make time to do several other visits. And there were successes that we saw in the supervision system. We noticed that the GCSV, or the general community health volunteers, were motivated. When you go and visit them and see them, they feel like part of the system. And also, there's also help for the National Malaria Control Program to take ownership of the case management program, because they were part of the monitoring activities at the community level. And also the competencies and the work of the community health worker were very successful. Thank you.
Only 1 minute remaining? Okay. Let me add a little bit. The MCP project in Uganda relied basically on the village health teams. And we instituted a supervision protocol at 2 levels. The first level was a joint support supervision done together with the district health teams and then the project staff. We would go out to the community on a quarterly basis and visit the health facilities where our female VHTs were placed. We would look at how they were working. We look at the challenges they had, challenges related to supply chain management, human resource levels, and others which were interfering with the implementation of malaria programs. So for the findings of this quarterly support supervision would then be shared at another forum at the district level. So this gave some element of ownership and sustainability because we were using the already established structures to carry out the support supervision. The other level was the routine support supervision which the project staff conducted, going to the villages and doing spot checks on homes because the VHTs were supposed to do home visits. So our project staff would go and visit homes at random to see whether these people they did the home visit, and also to cross-check whether the messages they were giving were consistent with what has been given to the VHTs to produce. So this two-way supervision protocol made sure and enabled that to ensure sustainability. Now that we are gone, the district will continue to do the routine, the quarterly support supervision, which is, I think, good for the project. If we did not have this support supervision design, I think it was going to be very difficult for us, I think.
Thanks. The malaria and HIV epidemics greatly affect one another, influencing both prevention and control of each disease. How have your projects accounted for this interaction or considered integration of care and support of people living with HIV and AIDS?
Thank you. Realizing the deteriorating effect of malaria and HIV/AIDS and people living with HIV/AIDS, we trained home-based caregivers through the NEPI program. In New Patterns Initiative, this is actually a PEPFAR program for our HIV/AIDS and the prevention. So we have used these volunteer home-based caregivers to go house to house to HIV/AIDS, to people living as HIV/AIDS houses, and teach them how to use the LLIN, long-lasting insecticide net, and they were also promoting in seeking of treatment in early of the symptoms of this malaria. So we have been engaging these home-based caregivers, especially those who were very experienced in especially taking care of people living with HIV/AIDS. These people are also these HBCs or home-based caregivers are mostly they are HIV/AIDS positive by themselves, and they know how to treat these people and they know how to teach. And because of this, we have tried to integrate these two programs, our PMI, PMCP program and the HIV/AIDS prevention and the treatment program. So, so far we have gained a lot of benefits, especially by integrating these two programs. And people are, as children under 5 and the pregnant mothers, these people living with HIV/AIDS group are also exposed to malaria. So it was very important, and we have given very importance to address these people. And by the way, I was supposed to add in how we are using, in addition to government structure, the other community groups and other groups. In Ethiopia, our projects used in our organization have used FEBOs, faith-based organizations, mosques, and churches. Because of this, we have gained a lot of results throughout the program. And there was misconception about malaria, and the government was trying to distribute ITN, this mosquito net, to individuals, to householders, but because of lack of knowledge, they were not using it. And the influential group of people are these religious leaders. We have used these people and to teach the community about how to use it. Because of the misconception, as I said, people were not using that net. Instead, they were using for clothing, and they were also putting on the ground and put something else on it, and they were not using. Because of that, they were sick and they were dying. But because of these religious leaders, they, highly engaged in the program. I was telling to Julie and to others, not only reading our reports, but if you come out there to the field, you can see how your money changes the life of these people. And you can see, and you will be proud of investing your time, your money, because people are saved. People are not dying anymore because of malaria. And because the very instrumental people who take part in this, especially in this with behavioral change communication, the religious leaders. That is what I want to add. Thank you.
In addition to that, in Malawi, if you try to link the malaria versus HIV as a project, we have the National Malaria Prevention Communication Strategy. So as a project, we try to analyze it and try to relate it with the issues of cross-cutting or mainstreaming, whereby the strategy, we mainstreamed HIV and AIDS into the malaria communication strategy. Why did we do that? We are looking at the issues of HIV, and when you look at the illnesses which are part of the opportunistic infection in HIV-related cases, you find that malaria is #1. So we are trying to bring the attention of the linkages which are there between malaria and HIV and AIDS, and most of the common signs and symptoms which are there within malaria, or somebody when he just have or had HIV, they are almost similar. But we're trying to promote that if the HIV, in HIV cases or people living with HIV, if they have also access to the use of long-lasting insect nets, that could do even better than any other individuals. But also, we have been working with the National Association of People Living with HIV in Malawi, whereby the groups which are within the project area have been trained in malaria prevention, control, but also message dissemination. And when we are doing the universal net distribution, these were also targeted specifically through their networks, so that when you go back, you could have data for the number of people living with HIV who have managed to access the free nets within their households, and they are able to monitor the usage of those particular nets among themselves as a part of the target group. Thank you.
So though your project's focused on malaria prevention and control interventions, your strategies and activities incorporated capacity building efforts for both communities and facilities in a manner that has allowed them to apply these skills beyond only malaria control. So can you speak a bit about capacity building efforts and how this links to the health delivery system?
Regarding the capacity building you know, after this program is phased out, who is taking responsibility in continuing this project? And from the conception of this program, we have been trying to build the capacity of the communities that we are working in, and you know, to not to stop this activity and to continue by their own resources. But you know, we build their capacity by providing the multimedia, you know, supplies like radios, megaphones, tape recorders, and the different kinds of tools. And in addition to that, we have trained the faith-based organizations, community-based organizations like youth associations, women associations. And finally, when we closed out this program, and we signed a memorandum of understanding with the Ministry of Education, with the Ministry of Health, and with the religious leaders, and to continue the program because they already gained the necessary equipment and the necessary training to continue this program. It will not be an issue of sustainability about this program once they have their capacity is already built, and they showed interest to continue with the program. And more than that, the results that they have seen on the ground can motivate them to continue the program. So this is what I want to say. Thank you.
Yeah, also, as a part of sustainability strategy, in Tanzania, we also train the healthcare providers. Apart from working with the community health workers, we also saw the need of having healthcare providers, those who are working in various health facilities, because these are the people who will continue working there, and the pregnant mothers and the under 5 will be still needing their help. So for us, we train the healthcare providers, especially those who are working in reproductive and child health unit. We train them in focused antenatal care. It's a comprehensive package which addresses all the issues related to pregnant women, including malaria. So it's a part that our program was dealing much on malaria, but the package of focused antenatal care, it addresses other issues as well. So this it is another way of making sure that the knowledge remain within the project area to be used by the pregnant mothers who will be in need and the children under 5. Thank you.
Okay, to add on to that, the sustainability strategy we started all the way as we started our project, in that by the time we were identifying the CHWs, we identified together with the community, that is where we are having provincial administration, where we are having church leaders or religious leaders. So these are people who are accepted by the community, so which means even if our project winds up, they are still accepted and they continue working. And then we went on training them as part of the capacity building. Then we also did the provision of equipments such as referral books that they use to refer patients from the community to the health facility, and the channel of communication becomes two-way, in that they also provide the information from the health facility to the community. So that is how we work. Then you find within the objective 2, where the two are joined together, as I mentioned earlier. The CHIU is the link man, the link person between the CHW as a group and the health system as a group. So you find that they provide the information. And we talked about the CBOs, the community-based organizations that we work with, and we subgranted 10. These 10 CBOs, they are trained all around, from proposal development, organizational capacity building, and all that, and even monitoring. So you find that now they can stand on their own and they can source funds from other local organizations, and they run health activities within the villages or within the communities that they serve. And within our catchment area, we are having 10 CBOs or 10 community-based organizations. That means we are having 5 districts. Each district is having 2 community-based organizations. Then, as we are also planning to wind up the PMI project, we are having the meetings, the CHW or community units are having meetings together with the district health management teams, so that they know where we've come from, where we are, and where we are supposed to reach. So you find that we are not leaving them hanging, but at least there is a continuum. Thank you.
In addition to that, in Malawi, the project used the existing health services delivery system. What we avoided was to use the parallel structures which will work against the health services delivery system. So find that the implementation of the whole project was within the national health services delivery system, whereby our role was to strengthen the capacity of those structures from the community level to the district level. But also as a nation, we're implementing what we call the decentralization policy. So the decentralization policy encourages the communities at the village level to make or to demand the needs for the services for themselves. So the project was integrated within the systems which are there, and our role was just to strengthen them and even provided the resources, which by virtue of winding up the project, the systems are already there in place, but the addition is that they have been strengthened and they're able to do their work and know their roles and responsibilities well, which ensures that the activities or the progress which the project has made will continue using the existing structures.
Just to add that for us, we will continue training teachers for rural areas together with the Ministry of Education. Therefore, our students, after their graduation, also they commit themselves to do activities about malaria in the community. So as a school, it will continue to be there. And then those teachers and the school director, they've made agreements to commit themselves to continue with the activity about malaria in their community.
Thanks. I have one last question for all of you before then I open it up to the audience to step up to the mic and ask your own questions. But building on Evaristo's last point, arguably, community ownership leads to more successful programs. How has your project found this to be true? Has your project found this to be true? And if so, what strategies or activities do you implement to ensure community ownership of the project?
So when we have started the projects, first of all, we had to make sure that our strategy is part of the national policy. And then on our national strategic plan, there is also the line called communication for behavior change. And then the school itself, strategically, it's indicated as a good example how to approach the schools and the community. So we have made these specific agreements with the municipal level, so that those group of teachers, those local authorities that we have trained, they will continue the link with the authorities. As I said, our school for training of teacher will continue. So the ownership of the project also, it will be on this sense that the connection between the schools and the teacher with the community, the activity of malaria will continue. And also we have, as a good consequence of the project, we have elected as the president of the National Forum of Malaria. So again, ADBP has a responsibility in the province to coordinate all the activity about HIV/AIDS or about malaria. And one of the examples is that we have developed tools also, like book for manual for teacher, and also manual for students and for authorities. And then the government, the Ministry of Health, decided to launch those manuals as a national tools. It means that from now it will be used also for other NGOs as a good experience how to work with the schools.
Ensuring this malaria community program ownership of the community, you know, it was known that the government owns this program, but the community didn't. What we did was for the community to own the program. That's why we trained religious leaders. That's why we trained community health extension workers. That's why we trained school teachers, students. We found, we established anti-malaria drama clubs. Also youth associations and the women associations. These all groups, attended different trainings. And now, as I said earlier, when they see the result, what this MECP program brought about, they are initiated by the result, by the outcome. Because of that, now they said, it is not government's program, it is not USAID program, it is not PMI's program, it is our program. It saves our life. We will continue. We will own it. We will find resources to continue. And this is what community ownership means. So that's why they signed a memorandum of understanding with our organization to continue. We gave them the training, we gave them some supply, equipment for, IAC and the behavioral change communication program, and now they have everything, they have every tools, they can continue by themselves. And so the community ownership is there in regard to MCP program. Thank you.
Yeah, on additional to that, the component of supervision is what actually has been making sense to make the program to keep on going. The supervision of the community health workers, whatever. They are owning the program, community health workers, the religious leaders, but if supervision is lacking, it becomes a problem. Now, knowing that, we advocated this to the district medical officers. And for our case, in this financial year, all the districts which we have been working with, they have included in their budget the component of supportive supervision to the community health workers. So this, it will continue motivating the community health workers and other community stakeholders to keep on working on the community interventions. Thank you.
And in addition to that, and in terms of the ownership, I could really agree with you and appreciate that the projects targeted the places or the areas where we had high cases of malaria. So the project was ideal for the place where it has been implemented in Malawi. Hence, communities participated very well and also seen the fruits of the project, and that has made them believe that the activities has to continue, whether we are there or not. But what they indicated was that the project was meant for them, and it's them who have seen the changes which has happened over the years, rather than possibly the project staff who worked as the machinery to move the information to the community. So the project was addressing one of the major health challenges within Malawi, which is malaria. So that made the communities to own the overall of the activities, and yes, at this moment we are celebrating that it has brought significant change in their life in terms of their health delivery system. Thank you.
I'd like to take a few minutes and open it up to the audience for any questions. But after that, we invite you to a reception and to take a look at all the posters that each of the grantees have put together. So if you have any questions, please step up.
It's great to hear all of your experiences. I'm Jean Capps, a consultant, and I wrote 2 of the MCP grants that eventually were awarded. And I have worked in malaria in all of your countries. I'd like you to address the impact or influence that commodities or lack of commodities had on your projects, knowing that in most cases you were not responsible for the commodities. They were coming from government or from somewhere else, another partner. And if that had any influence on your results, and that includes nets and drugs and RDTs.
A very good question. You know, in our MCP program, we are educating people. We are creating demand, but we are not supplying nets or IRS, anything. In the first year of our program, that was a problem. You know, we taught the people and we educate them, and we are addressing the importance of ITN, but there was no ITN there. And the people are asking, okay, you educated us, you taught us, and where is ITN? And it was really a program. But we do have a good relationship with the government and we are with other service providers like UNICEF and ICAP International in Ethiopia. And we have discussed with them, and we have a malaria consortium at the country level, and we try to address this problem, especially in our targeted area. You know, the government gave priority because the people are crying. You know, just we understand that the mosquito is going to kill us, but we don't have the net. And if this is also a concern for the government, and automatically they try to respond it. After the second year of our program, that problem is not anymore a challenge. Thank you.
Yeah, apart from various NGOs which are receiving funds from PMI, the government of Tanzania also is a recipient of PMI funds. So on every month, we have a meeting of all PMI partners who are working on malaria. So this issue, as my colleague said, it also arose in Tanzania. But because we have this meeting on a monthly basis, we addressed it, and it came clearly that some other partners who were supplying other commodities, they also take serious initiative. Like the government, in collaboration with the other PMI partners, they are involved on the mass badness distribution in the country. That was the second year of MCP implementations. So as per now, every household is covered with enough badness according to their sleeping sites. The same applied to the SP drugs for IPT. Also, there's another PMI partner in collaboration with the government. They're also taking serious measures to make sure that we have the adequate supply of SP drugs. So the collaboration of PMI partners within the country is really helping. It helps us to get out of the mess. Yeah.
Yeah, in addition, advocacy with a government agency that is responsible for bringing ED supplies is one of the key activities that we are engaged with the National Malaria Control Program. We know when we were doing the community case management, where we need a RDT, we need an ACT, we need a glove, which are provided by the government. We work with those people that are responsible for the supply chain, make sure that we document every activities at the community level, show the needs that these resources, these commodities are needed at the community level. Once you document properly and you can prove your case, then, of course, those that are responsible will be willing to listen to you and help to provide. We have problem with net distribution in the community that we work. There was net distributed, but did not cover all the community, but we have provided health education, we have provided the need, and the people, we provided the demand, and the people are requesting us. So we have to take the government representative to those areas, and the beneficiary have to talk to them directly and ask for what they need. So when the request is coming directly from the beneficiary, they see the need, and sometimes they can act, because it's not only PMR net that were in the country, there was also global fund net that were in the country that were diverted to other places. But making your case and doing your documentation can help to solve some of those problems, but it's always there. You just have to advocate and work harder to work with the system to straighten it, then that will help to alleviate some of the problems that we face when it comes to shortage of this commodity in the country.
Okay. Thank you for the question. I think for our case, we are running an integrated project, but our main focus has been capacity building, though we have an element of commodity supply that is long-lasting insecticide-treated net, which is being provided to children under 1 year and pregnant women. So this is a continuous process, and you know, in our national malaria control strategy is running from 2010 to 2017. So the first phase has just ended, that is preparing the ground for actual commodity provision. So, and based on to this phase evaluation, the malaria prevalence has gone down, and now we are in the phase that is running from 2013 to 2015, where we are going to deal much more with the commodity provision, where we are going to work much more on the provision of ACT and RDT, and making sure that microscopy is also running alongside. So based on to that, we have realized the reduction in malaria prevalence as per se in our country, Kenya. So thank you.
In our province, for example, it's, we face some challenge. Zaire province, where we had the project, is one of the most affected by the war. And the health facilities were destroyed. The human resource is very lack. And then we had to use our network with the other organization, with the government, so that they can cover other necessary things to be done in the province, which is not part of the project. For example, we had to make advocacy so that the Ministry of Health sent facilitator to train the health staff in the health centers in the provinces. And also at that time, we have mobilized a lot of people, but the distance to the health centers, it's too much. And then people also, they don't used to go to the hospitals. Because of this poor service, they lose confidence to the services. And that was in 2009 when we started. But after our mobilization, also they increased the number of cases notified in the clinic. It means that more people, they start to use the clinics, and also increase the number of people who is using mosquito nets. So it was also then the government starts to gain confidence on the projects. And then just last year, they have made the impact stats about the project. And then they can see that the number of notified cases increased, and also the death of malaria reduced. I think no deaths, no pregnant women died about malaria in last 2 years in the province. So it means that it's, and also we were pushing the company who is doing like the oil exploration in the province to push them for their social responsibilities. And then they started to do something. We pushed the other small NGOs that just they can do the work in the community together with us. And then it was very important to reinforce the community response. And at the same time, it's not just about mobilization, but also about how to improve the services together with the Ministry of Health.
Okay, yeah. Thank you very much, consultant, for the question. We have noted in the implementation of this MCP project in Uganda that when you create demand, there is need to match that demand created with availability of services. The MCP project in Uganda was not mandated to supply insect-treated nets, but after sensitizing the community, creating demand, they went to the health facilities, and sometimes they find the nets are not there. They would take their children, after referring them, they find the ACTs are out of stock. So it sort of caused a problem to the project. But we kept on engaging the community through community meetings and through different meetings to ensure that if the nets are not there, the government or the other partner who is supposed to supply us not, you should be able to save something and buy it on your own. Or another partner called Nomad was supposed to supply the nets, but unfortunately their term expired and they closed. So we had about a year when we did not have the nets being supplied. Even when they were still there, the supply were inconsistent, and even in very small quantities. So we have noted and we have recommended it in our end of project evaluation report that in future interventions, there is need to match the demand that we are going to create with availability of the supplies if the health gains that we want to see are really to be realized. So the supplies which were inconsistent sort of watered down our achievement, but all the same, the project did all it could, and the results are pretty impressive. So that has been, I think, a key sticking issue that needed to be addressed. So we were thinking if MTI was given the mandate to create demand and supply these nets and ACTs, I think the achievement could have been better. So supplies remains a very key challenge that needs to be taken into account, I think, in future interventions of similar programs. Thank you.
Hi, Leo Ryan from the MCHIP project, and I'd like to first thank you all for coming and being on this panel. I think this is an incredible opportunity that we have to really learn from the field, and it's been very exciting to hear about the different accomplishments. A lot of the things that you've talked about, that you've done, I think are things that line up very well with some of the priority areas that we've been trying to advance in MCHIP and that USAID's been trying to advance: country ownership, community involvement, all those kinds of things. The question, I really want to take advantage of you all being here and get your honest opinions, answers to this question, which is one that I wonder about a lot. And if we think about the PMI initiative and the idea to have national malaria control programs and to have national level programs with lots of different partners involved to make it all work at the national level, the thing I wonder about is what is, and you're all working for NGO organizations, right, and PVO organizations, what is the value added that an NGO brings to that process? Like, why should NGOs be involved? Why shouldn't there just be a bunch of other partners? You know, many of you said, well, the Global Fund's there, and you know, there's lots of big bilateral programs and things like that. So what's so special about NGOs? What do NGOs and PVOs do? What do they offer in this kind of program that nobody else could offer? And I just like that from your experience and you know, your long histories of working in the field. Thank you.
Yeah, thank you very much. We know that the National Malaria Control is there in the country and they are responsible to take care of these activities. But most of the time they have a lot of other activities that overshadow those community engagement that they need to do, so their focus is mostly at the national level, and there at the community level where things are happening are mostly neglected. Theoretically, they were decentralized, but you won't see the effect at the community level. So what the NGO does is we work directly with the beneficiary at the community level and trying to build the capacity of the National Malaria Control Programs. And the results that we get at the community level are brought to the National Malaria Steering Committee meetings. And these result in our activities and our successes and challenges can help to direct the strategies of the National Malaria Control Program. So we are there to augment their effort as long as we are working in the policy of the government. Thank you.
For the country like Angola, it will take some time before the government take over the whole responsibility about the health. Right now, it's because the national program right now is more about the policy and the orientation about the health system, about the policy. But the community health system, still that is a specialty for NGOs. This to approach the families, the people, the households. I think it will continue to be specialty for the NGOs. Right now, we have started 2 years ago what we call the revitalization of health system, where the government has responsibility about training of human resource, constructing and reconstructing new health centers, and the civil society has responsibility about the community mobilization or mobilization for communication for behavior change. So this will be speciality for NGOs during some years. And this is what I can say is a specialty for NGOs. But to make it sustainable, it will be on this way that is complementary efforts of what the government is doing and what the civil society is supposed to do.
Yeah, thank you. In Uganda, the NGOs don't work alone. They work in close collaboration with the Ministry of Health Structures, the Malaria Control Program. So they assist the efforts of the government. So in essence, the NGOs are more on the ground. Most of them, they work at the local level and they engage the community members more closely. And because sort of they are small in size, their interventions are much more focused and their results can easily be seen. They work together with the Malaria Control Program so that their policies are in line with the strategic control, the Malaria Control Program of the Ministry of Health. So there is still need for the local governments to be there. You know, the government at times is too large. If they are to be given to run the programs entirely, at times they might not have the time because of competing interest. Others have to go for meetings. You come to the health centers, the staffing is not enough. So we need this local, the NGOs to fill in the gap. But if the system was to be very efficient, as he said, then it would be much more better to work through the government system. But in our country, in Uganda, and I think in most other countries, the system is not all that very strong. For example, in our country, especially in northern Uganda, the staffing level in some facilities is only at 30%. So if it is this health worker who is supposed to see clients coming, this same health worker is supposed to go and mobilize, go and participate in community meetings, nobody will be there to see the clients. So that's why the NGO at this time are still very important to fill in the gap and work together with the Ministry of Health and then all those established structures to see that the services they're providing is of the recommended quality and consistent with the national plans for such specific interventions.
But also, in addition to that, the existence of the NGOs within the implementation of the malaria activities acts as a cross-checking or cross-examination of whatever the policies are there in terms of national malaria control program. So that we find that you have got good policies at the national level, but you go to the communities, they are not aware of that. So the implementation or the translation of that policy into action, most of them is done by the NGOs, because you find that sometimes there's a conflict of interest among the health workers to translate the policy into implementation at the community level. So existence of the NGOs made it that the communities are aware of the policies which the government is promoting, but also demand for such services which they will get it from the health services delivery system. But also I should agree with the previous speakers that most of the countries, you find that the health worker to population, the ratio is just too big. Hence, there's now a need to concentrate more efforts on the communities themselves to take responsibility of their